Hey everyone, the question we're going to answer today is outline the physiological roles of calcium in the body. The framework of this will be defining calcium and the question. We'll talk about functions and we'll break this up into structure, so bones and teeth, haematological, such as clotting, membrane potentials, excitation coupling, and particularly muscle contraction, cell signaling, cardiac electrophysiology, and neurotransmitter release. So there's 7 areas that we'll cover in function. To begin with, to define calcium, calcium is a mineral and it's important to all cell function, signaling, and structure. If we were to draw a cell here and talk about the concentrations of calcium, so internally, intracellularly, calcium is 0.1 micromole per litre. Extracellularly, it's 2.2 to 2.6 millimole per litre, with 45% of that being ionized, and ionized means it's the active calcium is the more important number, which is about 1.1 millimole per litre. The other 55% is bound, so usually to albumin, citrate, and phosphate. And 99% of total body calcium is in bone, and the particular structural component is hydroxyapatite, which is a phosphate and calcium combination. In regards to structure, so calcium, 99% of calcium is in the body and stored in bone. Calcium plus phosphate gives bone its rigidity, and bone is also a store of calcium. So decreased calcium, you'd expect osteoporosis, so weak bones, weakened teeth enamel and brittle teeth. Raised calcium, you expect calcium deposition in skin, arteries, and you can get renal stones that are also calcium predominant. Haematologically, calcium is an important cofactor to the coagulation cascade. Without it, your blood cannot clot. And this is why, for example, in massive transfusion protocols, we give calcium because a lot of the blood products have citrate and other calcium-bound substances in them. So when you give it to someone who's bleeding with a massive transfusion protocol, you don't want to give too much because you'll make them anticoagulated if you don't give them calcium. Another clinical relevance in the ICU is in renal replacement therapy, there can be citrate anticoagulation. And this is because you'll give citrate to the patient or to the circuit, and this will bind up calcium, meaning the blood in the circuit is anticoagulated. And when the blood is returned to the patient, you need to give calcium back. You can see here, this is a very simplistic diagram, but on the left, there's blood entering the circuit. Citrate is then given. Citrate in blue bounds up the calcium in green. The blood can't coagulate while it's in the circuit then. And then as the blood is returned to the patient, calcium is given back to the patient, and citrate's then broken down in the liver. Resting membrane potential is important. So like we mentioned before, calcium is very low inside the cell, 0.1 micromole per litre. And outside the cell sits at about 2.2 millimole, but ionized is 1.1 millimole per litre. So if you have less calcium, you're going to have cell membrane becomes more positive, so closer to threshold, which means it's more easily excitable, you're more at risk of tetany, and there's more permeability to sodium channels as well, because voltage-gated sodium channels will reach threshold. You'll get more nerve firing, more muscle contraction. And the opposite is true for high calcium, which will reduce the membrane potential, essentially hyperpolarizing it. Calcium is crucial for excitation-contraction coupling in muscle cells. So calcium influx in any tissue with sarcomeres, i.e., for example, muscle, will contract. So calcium enters the cell and it binds to troponin C. The tropomyosin complex then changes shape, which means that the myosin binding site is freed and allows actin to bind to it, and this leads to muscle contraction. Your calcium doesn't just sit outside the cell and enter, it also sits within the sarcoplasmic reticulum or endoplasmic reticulum. So calcium is also used in cell signaling and many different signaling pathways. The example I'll use here is a G protein coupled receptor, specifically the GQ PCR. And this is the one that noradrenaline will bind to. So NORAD binds to it. This leads to phospholipase C activation of the PIP2 protein and enzymes leading to IP3, which then binds to the endoplasmic reticulum calcium channel, allowing calcium to be released. Calcium signaling and effect takes place, and in this specific example with noradrenaline, this would lead to vasoconstriction. In regards to cardiac physiology and electrophysiology, calcium is a key ion in cardiac pacemaker and ventricular myocytes. This is an action potential of a pacemaker. So the more up it goes is the more positive the membrane potential of the pacemaker. And you can see that phase 0, which is when we're going up and becoming more positive, calcium influx occurs. So if you've got too much calcium or not enough calcium, you're going to be at more risk of ventricular arrhythmias. In regards to the ventricular myocyte, of our phases, phase 2 is calcium influx, and this is the plateau phase. And this is also represents the contraction of the cardiac muscle and maintaining and holding that contraction to allow blood to exit the ventricle. So if you have decreased calcium, you're going inside the cell, you're going to have decreased contractility as well. As a general rule with the ECG, decreased calcium leads to prolonged QT intervals and increased calcium leads to shorter QT intervals. Lastly, we'll talk about neurotransmitter release. So here we have a pre and postsynaptic neuron, and we've got the synaptic cleft. You can see that there's a voltage-gated calcium channel that sits on the presynaptic neuron, and in yellow that's myelin. And we've got little vesicles with neurotransmitters inside them in the presynaptic neuron. In blue, the action potential comes along the neuron. It then leads to depolarization of the presynaptic cell. Threshold is met and voltage-gated calcium channels open. Calcium can then flow into the cell, binds to the vesicles and other proteins within the cell and activates secondary messengers as well. And this leads to excitosis of the neurotransmitter into the cleft. So calcium facilitates exocytosis of neurotransmitters. To tie this back to our point about membrane potential, when calcium is low, our membrane potential is more positive, meaning that we're more likely to be at threshold. So in a sense, you as well, even though you might have low calcium and calcium is involved in neurotransmitter release, if you have very low calcium and your membrane potentials are very positive, your voltage-gated calcium channels and your voltage-gated sodium channels will be open, and there will still be ongoing action potentials or more excitability of the nerve cells, which means you can still lead to tetany. So don't confuse this in your head when you're thinking through this, that high calcium leads to tetany. In fact, high calcium will lead to depression and less excitability of the nervous system, or you lower the membrane potential, meaning you're less likely to reach threshold potential, leading to voltage-gated calcium or channels or sodium channels opening. So low calcium is going to be associated with more nerve excitability and tetany, while high calcium will be associated with suppression of the nervous system and less cell excitability.